So that gets to one of the questions I wanted to try to understand is the breakdown, or at least your experience clinically in terms of who's being diagnosed in the rheumatology world, who's being diagnosed in the pulmonary department, how those breakdowns happen, how you communicate, and if that makes a difference even in terms of how payers are responding to your requests.
Yeah, I mean, I often, when I give talks, I often show this slide of an elephant with a blind person, with blind people touching different parts of it. Because, you know, as a pulmonologist, I see something different than a rheumatologist sees, than maybe a cardiologist sees if they have had a patient present with pulmonary hypertension. And so a big part of the challenge is really making sure that we communicate with each other, and that rather than just seeing the single part of that disease, that we recognize the holistic part of the holistic nature of the disease. So fortunately, I think that you know, I'm blessed to be at an institution where I actually spend my time on Friday afternoons in clinic with rheumatology and neurology side by side. So when we see patients often together. And that's sort of a luxury that I don't think that everybody has the opportunity to enjoy. And so I think that in the absence of actually being able to grab your rheumatology colleague and drag them in the room with you and say, hey, what do you think about this finding that I have on my new ILD patient? I think that it's really key that there's open lines of communication where pulmonologists who may be seeing the patients, or rheumatologists, whoever is seeing them, firstly is communicating with the patient, because the patient is their own best advocate, and often is the person who carries the information between specialists. So every patient should know what they have, why we think they have that, what their testing is. I usually have my patients get a little binder and carry their lab studies with them. And then to communicate with the primary care provider, who really hopefully is serving as the hub of care for the patient and is making sure that all of the specialists are coordinated. And then last but not least, I mean, for our patients with autoimmune lung disease, I mean, I always try to communicate directly with the rheumatologist, because a lot of our therapeutic decision-making has to be joint therapeutic decision-making. And so, you know, it's so much easier if we're talking to each other than if we're just kind of each launching out in our own direction on how we're taking care of the patients. And I'm sure that Laura has probably a slightly different view, because she sees patients mostly through the rheumatology lens. But so what would your view of that be?
Yeah, no, I totally agree. I think communication is key. You know, in rheumatology, we're in the position where we're screening a lot of times for lung disease, hopefully before it's happened or before it's progressed. And then we get our pulmonary colleagues involved when it does. But I think the treatment is so important to be a shared decision-making process in the rheumatic diseases in particular, because you know, the pulmonologist may not be aware that, you know, their joint disease is active, or they've got new muscle inflammation that requires therapy, or their skin disease is active from their scleroderma. And, you know, there are medications that potentially could be used for both, or one could impact the other. So, I mean, it really does have to be a shared decision-making process.
And can I ask you a question about that, which is, when you're requesting medications, are there medications that payers are saying have to, or requests for medications that the payers are saying have to come from a pulmonologist?
You know, I have not had that experience yet, because I see mostly scleroderma patients, and nintedanib has only been approved for a fairly short period of time. You know, I've only had the opportunity to prescribe it for, you know, a handful of patients so far. So far, I have not had an issue where they said it has to be coming from a pulmonologist, but it may just be, I just need to, you know, gain more experience with more payers that I might run into that issue.
Dr. Oldham, do you have anything to add to this discussion on the coding and some of the breakdown between pulmonologists and rheumatologists when looking for treatment paradigms?
Yeah, just to reiterate that it's very much a team sport. But before we can talk to one another, we have to acknowledge you know, that a patient coming in with ILD might have autoimmune disease, or a patient coming in with autoimmune disease might have ILD. And so, sorry, I like to joke with my rheumatologist that they're pretty good amateur pulmonologists. I'm a pretty good amateur rheumatologist myself. And, you know, that's required in order to work well together, because they have to suspect ILD when they're seeing autoimmune disease, and I have to suspect autoimmune disease when I'm seeing ILD.